Part 18, Normal Ventricular Conduction. Now let's go to points 11 to 15, which confirm normal ventricular conduction before we go and look for signs of ischemia or infarction. The mnemonic for these points is 3 widths and 2 heights. So give me a width and another width, and then another width, and then give me a height, and then another height. What are the 3 widths we need to look at? The first W or width is the PR interval, which we already mentioned in the limb leads. Now we just confirm it again in the chest leads. The interval is from the start of the P wave to the start of the QRS wave. It signifies the normal conduction of electricity in the atrioventricular node, and it should be between 3 to 5 small squares. What if it is less than 3 small squares? What do you think that could mean? A short PR interval could indicate that the conduction between the atria and ventricles is faster than normal, which can happen in a dangerous condition called Wolff-Parkinson-White syndrome, also known as the WPW syndrome. In this condition, an accessory pathway different from the atrioventricular node allows the electrical current to pass faster between the atria and the ventricles. This can result in critically fast heart rates. In WPW, we find the PR interval very short, but in addition to that, we find that the QRS has an initial sudden positive wave, called the delta wave, before continuing as the mainstream R wave. At the end of this part, we will explain a bit more why conditions like WPW need to be detected before diagnosing ischemia. But for now, what if the PR interval is longer than 5 small squares? Well, this can indicate a condition which slows down the atrioventricular node called heart block, which we will discuss later in this series. So, by finding the PR interval is between 3 and 5 small squares, this allows us to exclude dangerous conditions like WPW syndrome, which can cause dangerous tachycardias, and also exclude heart blocks, which can cause dangerous bradycardias. Now, what is the second W or width? The second width is the width of the QRS wave. It represents the simultaneous depolarization of the right and left ventricles and should be less than 3 small squares or 0.12 seconds. If the complex is longer than 3 small squares, especially with special patterns appearing, this could indicate ventricular asynchrony. This means that the depolarization of one of the ventricles is delayed compared to the other ventricle. So they are not depolarizing together as they should. This is a condition called bundle branch block or BBB. If the bundle branch block appears in chest leads V1 to V3, it is a right bundle branch block. That's right BBB. If it affects leads V4 to V5, it is a left bundle branch block. That's left BBB. Now, what is the third important W or width? The third W is the width of the QT interval, which is the interval between the start of the QRS wave and the end of the T wave. So it includes both QRS and T waves. This interval should be between 9 and 11 small squares in width. If it is longer than that, it can indicate a condition known as prolonged QT syndrome, which is caused by specific drugs and medical conditions and can also cause dangerous arrhythmias. Now, as we finish the 3 W points, let's go to the 2 points that start with the letter H for height. The first letter H is the height of the smallest R wave in the chest leads. This is the R wave in lead V1, while the second H is the height of the largest R wave in the chest leads. This is the R wave in lead V5 or V6. This progression of R wave height from V1 to V5 is actually called the normal R wave progression. What does it mean? Or in other words, why does it happen? Well, normally the right ventricle is smaller than the left ventricle in size, right? So as the V1 lead or camera is looking at the right ventricle and the V5 lead is looking at the left ventricle, it follows that the positive R wave in V5 should be larger than the positive R wave in V1. This is because they are not the R waves of the same ventricle. The R wave in V1 is the right ventricular R wave, whereas the R wave in V5 or 6 is the left ventricular R wave. I hope that's clear. So anyways, that is why the height of the R wave in V1 should be relatively 1/5 the R wave in V5 or 6. In other words, the left ventricular depolarization is normally 5 times bigger than the right ventricular depolarization. You must want actual numbers in squares, right? Well, in V5 or 6, the maximum height of the R wave should be less than 25 small squares. If it is more than 25 small squares, it can be a left ventricular hypertrophy. And in V1, the height of the R wave should be less than 5 small squares. If the R wave in V1 is more than 5 small squares, it can indicate a right ventricular hypertrophy. And as a side note, if there is no apparent R wave in V1, and the first wave of the complex is negative, that is actually a Q wave, which requires attention. Now, do you get it? Great. That actually concludes the 3W points and the 2H points. So again, these were the width of the PR interval between 3 and 5 squares, the width of the QRS interval less than 3 squares, the width of the QT interval is 9 to 11 or less than 12 squares. And then the height of the R wave in V1, let's call it the R minimum, is greater than 0 but less than 5 squares. And then the height of the R wave in V5 or 6, let's call it the R maximum, is less than 25 squares. Now, if these 5 widths and heights are normal, then we have successfully excluded many conduction or electrical abnormalities that can interfere with the diagnosis of ischemia. However, if the ECG has abnormal widths like WPW syndrome or abnormal heights like left ventricular hypertrophy, then the diagnosis of ischemia is more difficult and requires a more experienced doctor. For example, if the patient has WPW, then this can distort the electricity so bad that we can't really diagnose ischemia easily. It's like listening to a radio signal with too much static. It's much more difficult to recognize the signal from the noise, right? That's what bad conduction does to an ECG. Another example is left ventricular hypertrophy, which causes the mass of the ventricular muscle to increase. So even if the coronary blood is the same, the extra muscle mass demands more oxygen, and therefore, sometimes left ventricular hypertrophy is associated with ST segment and T wave inversions, which are known as left ventricular strain pattern. See, we cannot immediately call them a coronary ischemia. We call them a strain pattern first, until an expert can look at the ECG. If conditions like left bundle branch block coincides with true coronary thrombosis, well, a more advanced doctor will use more knowledge, like this Garbosa criteria, to confirm whether coronary ischemia is really present with the left BBB. But anyways, that's for advanced doctors, not beginners in the ECG to do. All that is required from you now is just confirm the ECG is normal, or wait and refer to an expert if the ECG is abnormal. Got it? Great. So now we can go and look for signs of ischemia or infarction in the ECG with more confidence. This will be the objective of the final group of points, points 16 to 20. See you there.